All right, I think we'll resume our conference. So we'll now begin our second session of the Region 2 PsychSIGN annual conference, which is virtual this year, 2021. And I'm pleased to introduce Dr. Jonathan Avery. He is the Director of Addiction Psychiatry and Associate Professor of Clinical Psychiatry at Weill Cornell Medical College, New York-Presbyterian Hospital. He'll be speaking on the stigma of addiction in the medical community. Thank you, and over to you, Dr. Avery.
Thank you very much. Thanks for having me. It's one of my favorite topics to talk about, and you guys are a great group to address it because you're our future addiction clinicians, whether you realize it yet or not. And so, and I think this is an important topic to think about early and often. And you know, I love being a medical student. Actually, my fourth year of medical school, I met my future wife who was also going into psychiatry. And so we're two psychiatrists, and we have a couple of kids that you may hear screaming in the background because I was saying earlier we're in between a play date and gymnastics. So I might periodically have to mute and scream at them, which is the psychiatrist way to parent, if you haven't figured that out yet. So, but on to the stigma of addiction. And, you know, I got married. I mean, I found my future wife on a psych ward as a medical student. But I also found a lot of opposition to the path I wanted to take in medicine. You know, I figured out pretty early in medical school that I really liked working with folks with substance use disorders. And I was pretty much given the immediate feedback that that is not a career I should pursue, that it was not worth it, that there sort of wasn't ways to make money or do research, or it wasn't a hot enough topic to dedicate one's med school interest to. And fortunately for me, that didn't deter me, but rather made me aware that stigma towards addiction exists everywhere, including in the medical community. And that ended up being the bulk of my research focus as I progressed through my career later on. And so I'll share with you some of what I've learned over the years today. Let's see here. So no relevant financial relationship. A lot of this content is taken from my Stigma of Addiction book. I did edit it with my brother. That's Joseph Avery. He's a lawyer turned psychologist at Princeton and soon Yale, and so he's looked at the stigma of addiction that exists among criminal defense attorneys and in the legal system. I'll share some of our work as I go through our talk today. Let's see here. And then a couple other acknowledgements at the beginning. You know, I don't think I realized when I went into med school as a medical student. I mean, my background is that my dad's a hospice physician, and I was sort of around psychiatry early on. I did a lot of dignity therapy as a high school student and college student, where basically we would help people at the end of their lives. I would film them, like create little videos about their story. But by the time I got to medical school, I think I was a little burned out on death and dying. And part of the reason I became interested in addiction was it felt like people who were, you know, really trying to figure themselves out were, you know, making a mess in the world a little bit. And part of it was a sort of a departure in some ways from hospice or geriatric psychiatry, which I had thought at different points would be my career path. But, you know, you learn in life that there's no avoiding death, it turns out. And no matter what you go into, it's around you. And so, it turned out that a bulk of my work as an addiction psychiatrist and a lot of the stigma work has been informed by family members who have lost loved ones to the opiate epidemic. You know, when I started out, I didn't imagine that I would be around so many families because I didn't really see them so much in medical school. But once you get into addiction formal, you see so many families struggling with loved ones who are suffering with addiction. And then, you know, we forget the families in the tens of thousands of people losing their lives each year to the opiate epidemic, that there's a whole bunch of people that you know, that are grieving. And as much as we hear about COVID-19 and the lives lost to that, I mean, the deaths from opiate use disorder over the last 10 years are many times more staggering. And so a lot of my work and the people I think are people like Robin Kellner shown here, and the Taylor Rhodes family at the bottom there, and a number of other people who have shared their stories to help combat the stigma of addiction and help people understand that, you know, what their loved one was going through was a disease and all the obstacles they faced along the way. And so I'll try to incorporate some of their tales as we go through this. The other group that I didn't imagine having much exposure to that have also played a big role in my stigma work are people in recovery. I think just as we sort of forget about the families, we sometimes forget that people get better, because once they're better, we don't interact with them so much in medicine. And it's just sort of a note in their chart. But the recovery movement is 24 million strong in the United States. There's 22 million with active substance use, 24 million in recovery. And so people do get better, and they want to share their story, and they want to, help us combat the stigma of addiction that they faced on their road to recovery. And so I always acknowledge both the families who have lost the loved ones and the people in recovery, because I don't think I could do this work without them. All right, so what are we talking about today? So I'm going to describe the stigma of addiction. I'm going to first talk about it as it exists in society. It's one of the take-home points, believe it or not, and you guys will learn with time, is that doctors aren't that much different than anyone else. I think sometimes we think as we go through medical school that we're sort of special in all sorts of ways, but we're not. I'm not. You guys might be special, but we're as prone to the biases that exist in our families and the media and society, and we'll talk about some of those, and then we'll talk about how that stigma translates to clinicians. And there's some unique factors that may even make doctors, medical students have worse attitudes than even the general public. And I'll talk about some of my efforts to improve stigma in the medical community, which include giving talks like this, and that's why I'm grateful you guys are here with me on this journey. All right. I mean, I think you guys know the statistics. There's as staggering as ever, the number of deaths a day, 10 deaths a day in New York City during COVID-19. Tens of thousands lose their lives around the country each year, and extend that to the lives lost around the world, and it's an amazing amount of loss. And we sort of ebb and flow as a society into how much attention we pay to it, but it's consistent over time. The numbers are still going up. I mean, we think right now we're in this third wave of the opiate epidemic. We've cut down on the doctor overprescribing. People turn to heroin, but now there's fentanyl all over the drug supply, and 70% of overdose deaths are fentanyl that's shipped in from China and Mexico and pressed into not just opiates, but into pills marked as Xanax, Adderall. And so about half the deaths a day in New York City, for example, are people looking to avoid opiates, people that end up with fentanyl contaminated product, and that's pretty dicey. I just talked about this, that we're still in the middle of this. There's a couple other epidemics, sort of the benzodiazepine epidemic, that are being overprescribed and play a role in the opiate epidemic. There's the youth vaping epidemic. There's sort of the trauma that's all over folks with substance use disorders. And so we are in the middle of an incredible amount of people using substances. During COVID-19, the alcohol data is astounding as well. 14% more alcohol being consumed. I think women are drinking 41% more than pre-COVID. And for the first time, we've seen so many women in the hospital. I'm on the consult service at York-Presbyterian and Cornell. I see people that come to the hospital with substance-related things. We've seen so many women in their 30s and liver failure with escalated drinking over COVID-19. And so, the numbers are pretty staggering. Oh, I have it here in the setting of everything that's going on. And so, add to that the economic cost of addiction, the way it sort of ravages our family, not just our lives, but our businesses, all of society. It's pretty striking. All right. That was just to say it's important. We should pay attention and be aware of stigma that exists to it, because it's everywhere. I mean, if the data is right, 1/3 to 2/3 of us in the Zoom call have substance use disorders in our families, right? I mean, it's everywhere. And so what is stigma? I think you sort of know, and this is one definition, but it refers to the negative attitudes towards individuals with substance use disorders or stigma disorder, any condition that arises on account of that condition itself, and then certainly impacts an individual in all sorts of ways. So I'm going to present a number of studies as we go through this, and a lot of it is survey projects, and they have certain limitations. I'll just highlight at the beginning. They tend to be smaller studies. They rely on this medical condition regard scale, which is a validated stigma measure, but it certainly doesn't capture all the things that go into why people have attitudes. And like any survey projects, there's low response rates. They rely on self-report. I don't know who answers surveys. I almost never answer a survey that comes into my mailbox, even though I send them out all the time. And so, there are certain limitations with the way this data is collected. But But my studies actually are rather readily accepted. They're pretty non-controversial. They're just characterizing something. But the major complaint about my work, as when I submit it to reviewers or when I talk in presentations or elsewhere, is people get upset about this idea of the disease model of addiction. Like, I can't talk about it anywhere with people just saying that it's not true, it's choices, it's an oversimplified neurobiologic explanation of things. And so I tend to start talking about stigma, whether we're starting off talking about it existing in society and we'll go on into medicine. But I think a lot of people in medicine disagree with the disease model of addiction. The disease model is simple, just to explain it. It's the idea that our brain gets hijacked we're understanding how complex it is increasingly. We used to think all roads lead to dopamine and that your reward system gets hijacked in a way that you get the dopamine spike about acquiring the substance. And basically it's just, everything just makes it very hard to change because your brain is sort of actively seeking out the substance in a way that becomes very biological. We've learned more and more about it as the years go on, and you should always check out Nora Volkow's latest article on the neurobiology of addiction. It's almost unreadable these days, just because it describes all the circuitry and pathways and the neurobiology of how we get here, and it's complex, and it's indicative of really a hijacked brain. And so we tend to argue that we should endorse this disease model of addiction because it helps us understand it like any other chronic medical condition as something that deserves our empathy and care, and not bad people doing bad things. But people often balk at it, and I'm okay with that. Like, if you want to not say it's 100% a disease model of addiction, I'm okay. And there are sort of alternatives, like Maya Solovitz, I always struggle over her name, talked about it more as a learning disorder, in Chasing the Scream and a number of other ways to think about addiction. People describe the different environmental and social factors, and the opposite of addiction is connection, and talk about all the different societal and racial and economic factors that go into why people end up with what's considered a substance use disorder. I think that's all fine, as long as we can all agree, no matter where you fall on this disease model of addiction, that it's really hard for people to do otherwise once they're in the middle of it. That these substances really pull on one that make it hard. And this quote sort of sums up how I feel we can all feel about it, even if we don't quite agree on the different ingredients that go into a disease model of addiction. Don't ever let anyone fool you into thinking that only weak or bad people get addicted. Addicts are not bad people learning how to get good, but sick people wanting and learning how to get well. And that's sort of the spirit of the disease model of addiction. And when you don't endorse it, it slips into a lot of things, including our language, and you talk about clean and dirty and addicts, and you don't separate the person from the disease. And so, people will argue it. And by the way, it's a small group, so feel free to unmute. I can't see the chat the way my screen's set up, but feel free to unmute if you have any questions. But we'll certainly have plenty of time at the end to talk about any of this, as you guys gave me an ample hour and 15 minutes here. All right. So there's a disease model of addiction that people agree or disagree. And I think that runs through a lot of the stigma that exists in society and the medical field. And I'll talk about some studies I did on in a second, but let's dive a little deeper into stigma as it exists in society before we talk about it in doctors. And I think this quote is so indicative of the issue. Americans love drugs, but hate the people who use them, especially if they are poor and or not white. We send these people to prison. So that sums a little bit of the societal attitudes in a nutshell, I think. All right, so what informs all the stigma of addiction as it exists in society? Certainly the media, they tend to depict it as bad people doing bad things, babies addicted to drugs, communities of problematic individuals who, shouldn't be with us on the Upper West Side, or shouldn't, be in our neighborhoods, and not people that, deserve our care. They emphasize individual culpability in explaining addiction and depict individuals, especially with drug addiction in a negative light. So I was talking more about the news and the newspapers and the media there, but certainly in our in Hollywood and the sort of media ways we depicted it often either as glamorized, like the answer to every bad thing that happens to you on a movie is to get drunk, right? If you get a breakup, if you get married, I mean, it's sort of the answer is to get wasted, and it's sort of glamorized. And, in recent years, people have tried to make more realistic depictions of addiction and emphasize the trauma that often exists. And BoJack Horseman is a little I mean, he's a horse to start, but I mean, it's a little, it's not quite, accurate, and it has all sorts of problems, but it talks about the trauma and the negative consequences. I thought Patrick Melrose was a pretty good depiction of the way trauma can inform future substance use and family dynamics. But certainly the media doesn't give a nuanced portrayal of addiction in any sort of way, and sort of emphasizes that it's either fun or it's not important, or it's for folks that don't deserve our attention, or they're just super handsome people that get in a brief trouble, but they're better. And then certainly race plays a big role in terms of the way attitudes in society are negative to those with substance use disorder. And this has been depicted in other studies, which pretty explicitly show that participants assign greater blame to Black individuals. It's been studied in other groups as well who developed drug dependence as compared to white individuals who did the same. Black participants perceived that their substance use problems were viewed less favorably than white individuals. And these racial stereotypes and drug stigma, are associated with views that these folks are violent or dangerous and are involved in crime. And even in professionals like lawyers and doctors and throughout society, there's this way, and it's influenced a lot of the way we regulate and make laws around substance use. And so, you can't talk about addiction without talking about the way the legal system, addiction, race, and the stigma of addiction all sort of collide. And these are the couple of studies I've done with my brother on it. I'll run through them quickly because we're focusing on the stigma that exists in the healthcare profession. But if the prison and jail numbers are so disturbing, where Black individuals are using similar amounts of substances, and the number of people in prison for low-level drug offenses, especially of those groups, is just way out of proportion and taking way too much of our prison system, and we're not offering people treatment. I mean, one thing notable about George Floyd's health timeline is he spent more than 10 months in prison for $10 worth of drugs, and none of it makes sense in terms of the way we punish folks with substance use, including legally, or even in the schools. We kick people out instead of offering them treatment. And it's just a real punitive and awfully racially informed way that our legal system goes about interacting with folks with substance use disorder. And there's a number of problems throughout the system that have been studied that lead to this: pre-arrest and arrest factors, post-arrest factors, and including all these different biases that exist in all members of the legal system. So my brother and I were interested in criminal defense bias. Basically, my idea is that the people that should be on the team of those with substance use disorders, like doctors and their own lawyers, are actually not on their team. They actually have negative attitudes towards them, and that negatively impacts their care. And so my brother and I have done a couple studies on this. One is looking at the attitudes that criminal defense attorneys had towards the disease model of addiction and how that influenced the care of their clients. And we sent one of these surveys out to 483 criminal defense attorneys. You can see the demographic problems right away with lawyers defending folks, right? You see it's mostly white and mostly male, mostly older. The lack of diversity in the legal field has been well documented. And we basically sent this to the lawyers. I did a similar study it was part of the same study we did with doctors. I'll talk about that in a second. But we asked them what statement they agreed with more. Sort of the first statement being the idea that it's a chronic relapsing brain disease, and folks with substance use disorder have practically no choice about whether to seek and use, all the way down to addiction primarily reflects a moral lapse. And the data was sort of as you might imagine, that fortunately most of them did, adhere to the models that looked more like a disease model of addiction. Although the degree to which you believed it was a moral failing, the more negative your attitudes were towards folks with substance use disorder, as you might imagine. So those that believed in the disease model of addiction had much better attitudes toward those clients, and those who thought it was more of a moral failing had worse attitudes. To give you a sense of what these studies look like, we basically put a little vignette on the bottom, and then put a person's face that has 16 different faces that vary based on gender and race. And so we looked at the disease model of addiction, And then we studied them again, just looking at attitudes overall and comparing them towards their clients with addiction, towards their clients with other types of offenses. And this was a bigger study, up to 2,000 criminal defense attorneys. And it showed that, the worse their attitudes were towards those with substance use disorder, the greater the belief that they would commit more crimes. But the criminal defense attorneys actually had somewhat better attitudes overall than the doctors in the groups. And they did, in some of the qualitative data, to have a little more hope because they felt there was more they could do for them than their property offense defendants, for example. But again, there was a trend that when people had more negative attitudes, that their how they felt about their clients deteriorated with time. All right, so I'm talking about stigma in society. It exists in the media. It exists because of race. It exists in the legal system. And then it certainly exists in the places where we work. I'm at York-Presbyterian and Cornell, and I'm pretty familiar with the medical students there. And all the time they're coming up to me with issues around addiction that they don't want to share with their other folks at the hospital and med school, because they're so worried about the stigma that exists, about getting punished for it, or losing the pathway towards being a medical provider, as one example. I mean, basically Brad Pitt's the only person that can say they have addiction and not get into trouble at work, right? I mean, everyone else, we often talk about this. I had this goaltender for the New York Islanders, even an athlete, Robin Lerner, a couple of years ago. He came out that he had bipolar disorder and suffered from addiction. He was like the leading goaltender. He was like 2018 or 2019, and no one signed him the next season because they were so worried about his mental health and substance use. And you see that, throughout. I talked a lot about it it exists in like bankers and lawyers, but every profession. No one wants to come forward because it comes with such shame. They worry they won't get promotions if they talk about it. If you had cancer, you would tell everyone at work. If you had any other sort of serious medical issue, you would tell them, and they'd say, "Oh, get treatment, take the time off. Your job here is safe." You tell someone you have addiction, and you worry you're going to lose your job. They're not going to trust you, so it's this, and the way these employee assistance programs are set up are so problematic. And so, I've increasingly been involved in that space. And then there's certainly stigma that exists in family members. The family is implicated through stigma by association. All these problematic terms, I think, like codependent and enabling, get wrapped up into it, and people view negative outcomes in children as being issues of parenting, especially with substance use. And as I mentioned at the beginning, this is Robin Kellner. I mean, she often talks about, everyone's doing the best they can for their kid, and the shame that came with trying to seek care, and all the obstacles that exist, and the way people view it as problematic throughout the family is just very problematic. And all the stigma in society, from the way we treat it in the media, the legal system, in our families and schools, ends up in self-stigma, which is the big problem at the end, right? Is that people feel shame. They start to view themselves as bad people doing bad things. They think they're failing, and that puts them in a position where they don't seek help, makes recovery less likely and more remote. It decreases their willingness to involve others and seek treatment for substance use. And then it impacts their work. They can't take time off work to do it. It impacts their family. They have to hide it from loved ones. It impacts their friends and relationships. And so the stigma situates the disease of addiction in a way that no other disease is situated, where you have to hide about it and lie about it. And it's important to remember when you see your patients with substance use disorder, why they may take time to be honest with you, because there's no space in their world where they can be honest about it, even with themselves at the end, because of the self-stigma. Because society has just totally taught people that this is something we punish you for, we jail you for. And so if you think, it's weird if they come to us and are honest about their substance use, because of the way society has been so problematic to it. And so it's important to keep that in mind when we get frustrated with it at healthcare providers. All right, so there's stigma everywhere in society. And then, of course, as I've sort of alluded to different times so far, there's stigma that exists in the medical community. And to highlight the attitudes right off the bat, so my studies and a number of other studies have shown that our attitudes as healthcare professionals are worse towards individuals with substance use disorders than towards any other medical or psychiatric condition. And then disturbingly, the attitudes get worse over time. So the first year medical student has the best attitudes towards the folks with addiction. You hardened MS4s in the room. By the time your fourth year medical students' attitudes have declined, and your attending that's rounding with you in the hospital, that 60-year-old ER doctor has probably the worst attitudes of everyone. And so, that's how it goes, and it's very disturbing. And so, we give people, when we study these, this is the medical condition regard scale I mentioned, which susses out a number of different attitudes related to compassion, to knowledge and skills, to basically how we should treat them as a society. And so I've studied a number of groups, and to assess out I won't go through all the studies in the interest of times, but we studied psychiatry residents, which I think most of you will be one day. And we showed that attitudes were worse towards those with substance use disorder than towards depression or schizophrenia. And even those with schizophrenia with substance use, we like those groups more than with just substance use, because we felt they couldn't help themselves with the schizophrenia. And so those with just substance use, we had the worst attitudes toward. And then again, the study showed that PGY 1s and 2s had better attitudes than the PGY 3s and 4s, again highlighting that the attitudes decline as people go through psychiatry residency, which we'll talk about in a second. And I did a couple other studies on psychiatrists, and was presenting this in Jefferson, actually, in Philadelphia, and in other places in Pennsylvania. And they highlighted that they thought there were other groups of clinicians that even had worse attitudes than psychiatrists. And, especially the emergency room, who was dealing with the difficult Kensington neighborhood in Philadelphia, where, it's characterized by really severe substance use. And then I got highlighted as I went through my career that there's all these complicated attitudes with pregnant women and substance use, towards how they should or shouldn't use marijuana, towards states that punish people for opioid use, legally punish people for opioid use during pregnancy. And so I extended my studies from just psychiatrists towards other groups, including the emergency room, internal medicine, and OB-GYN. And across specialties, all attitudes were worse towards those with substance use than towards other medical or psychiatric conditions. Among the specialty groups, emergency medicine had the worst attitudes towards those with substance use disorder compared to internal medicine, psychiatry, OB-GYN, and we'll talk about why that might be in a second. Even among, so one of my first studies as a psychiatry resident was, I was in this work group at a national psych meeting, and it was a group that had addiction psychiatrists and community psychiatrists, and both groups were arguing that they would have better attitudes towards those with substance use disorder and co-occurring disorders. And so we ran that study, and it turned out that addiction psychiatrists did have better attitudes towards those with substance use disorders, which is at least good. We know people that go into addiction seem to have good attitudes. So there's one group. And community psychiatrists have better attitude towards those with schizophrenia, as you might imagine, or serious mental illness. But actually both groups in this one, which was interesting, the addiction and community psychiatrists had worse attitudes towards those with co-occurring disorders. That is, once it got a little complicated, once the folks with serious mental illness got substance use, the community psychiatrists didn't like them as much, and the addiction psychiatrists as well felt less positive towards them. And so even among our most specialist providers, there's still a stigma that can seep in. And then there's this wonderful large European study in 2011 that used the same scale that I used for all my studies, the medical condition regard scale. And that looked at a number of professionals, physicians, psychiatrists, psychologists, nurses, social workers, and tested a number of conditions, medical conditions, psychiatric conditions, substance use conditions across a number of different states. And their studies were showed the same results as my studies, that attitudes were worse towards those with substance use disorders than any other medical or psychiatric condition, and they got worse with age or time in practice. So again, that deterioration as time went on. And then in my studies and in this studies, attitudes were worse towards those with harder substance, quote unquote, harder substance opioid use disorder than towards alcohol use disorder, as you're thinking about stigma based on substances that are used. And then there's certainly a big stigma that exists to the addiction treatments that exist. There's long-standing bias towards, especially towards the treatments towards opioid use disorder, people being on methadone or buprenorphine, the sort of quote unquote opiate replacement treatments or medication assisted treatments. Even there's stigma in those names, as opposed to these are meds that treat this condition. And there's this historic view that abstinence-based interventions are more appropriate. All the stigma that exists in different harm reduction initiatives, from naloxone rescue kits to syringe and needle exchange programs. And so not only do our folks get stigmatized, but the treatments that will really save them are stigmatized. And you can see all the problems that you can imagine, all the problems that might result from that, including that stigma in the medical community has been shown numerous times results in reductions in empathy and provider involvement, decreases quality of care and treatment outcomes. We know that those with substance use disorder wait longer to be seen in emergency room settings. They infrequently get offered the care they need when they present to medical hospitals. They're deprioritized overall. And there's been a number of reviews, including this good one in the Drug and Alcohol Dependence from 2013, highlighting the different ways that it gets in the way, our stigma in the medical profession gets in the way of care. All right. So why do medical students have these negative attitudes towards those with substance use disorders? Doesn't something special happen when we decide to be doctors, that we love all our patients equally and forever? Maybe not. And one reason I think is because we, as I mentioned earlier, we're not different than anyone else. We're prone to the same biases that exist in society, and we're prone to use substances more. Med students, you guys are more at risk to use substances than your age-matched peers. Psychiatrists and anesthesiologists, my people, more likely to binge drink on alcohol, misuse opiates and other substances. And so if we think we're immune, we're not even immune ourselves from substance use disorders. Our own use might be getting in the way of our bias. And then, as I mentioned earlier, 1/3 to 2/3 of us may have substance use disorders in our family. So we're coming at it with some personal experiences that shape our viewpoint towards these folks. And then, one thing I was surprised early on, because you learned a lot about the neurobiology of addiction as you go through medical school. You do learn, as I said, about this disease model. But the prevailing attitude is that it's bad people doing bad things, that, these aren't people that deserve our care and empathy. And so we looked at attorneys' beliefs and attitudes towards the brain disease model. We looked at physicians' attitudes toward the brain disease model of addiction. Those same 4 statements, from it being a brain disease to having some choice to it being a moral failure. And we looked at it in residents across specialties. And, we actually, compared to lawyers, physicians were less likely to endorse the disease model of addiction. And the degree that they believed it to a moral failing, the more negative their attitudes were to those with substance use disorders. So even among medical providers, we dismiss this disease model of addiction. All right, so I'm talking about why there might be stigma among healthcare providers. One is our own substance use. We're not different. 2 is we disavow the disease model of addiction. And then certainly we feel like we have the lack of knowledge and skills to take care of these folks, right? We feel like we're not equipped, from even taking the history to offering the meds, that it's sort of someone else's expertise and that we're not equipped to do it. The problem with that is, guess how many addiction psychiatrists there are in the country? There's like 1,000. There's like less than 50 to 100 graduate each year. There's none of us. We're rare. And so it is up to all of us to be addiction providers. And so we can't quite say we don't have the knowledge. We all should have the knowledge and skills, as we can, even if we're not experts in schizophrenia, we still can treat it. And even if we're not quote unquote the expert, we should have knowledge and skills, but people often feel they don't have it. Why else this group may be stigmatized is that it can be complicated, right? So there's a lot of co-occurring disorders that exist with addiction. And we often talk about the self-medication hypothesis of substance use disorders. And so it's not that you're just treating the substance use, but you're often treating co-occurring mental health issues, from anxiety, depression, treating trauma. I mean, trauma is sort of the unspoken epidemic in addiction. And so, these can be complicated in different ways, but if not us, who? And then certainly we're not immune to racial stereotypes and drug stigma. I mean, a lot has been made about the systemic racism that exists throughout medicine. And so, Just as it exists in society, it exists in the way we educate, the way we, throughout the hospital and medical school and community mental health environments. And so we can carry these same biases as the general public. One thing that's different, I think, about doctors than those in the general public, and one reason that attitudes do get driven down, is we do have these repeat negative experiences in the hospital setting. And I think this is why ER doctors, for example, have the worst attitudes, is that in training, in medical school, you guys are mainly in the hospital setting, right? And or some in some clinics where you're mostly seeing people in the most severe state of their disease. That is, you're seeing people coming to the hospital in intoxication and withdrawal states. And so, for example, the ER doctors, they're only getting repeat negative experiences. They're not getting any wins because they don't have that moment in the ER where they save someone's life and they come back and give them cookies for being in recovery. They're just the stabilization. So they only are stabilizing intoxication and withdrawal states, right? And so if someone's in recovery as an ER doctor, it's just a note in their chart and it's never their active experience of them. Same thing goes for psychiatry or primary care. They only remember the active substance use, and those are their repeat experiences. And once someone's in recovery, it just is like a note in their chart, and it's not what you're treating them for anymore. And so you think you're only losing. And so, I mean, there are 24 million people in recovery, more than with active substance use. The odds are for anyone presenting with opioid use disorder in their 20s and 30s, they'll be in recovery one day, but we lose sight of that and often that hope because of these repeat negative experiences, I think. And then there's the hidden curriculum that, I think also makes our attitudes worse as time goes on, is that we learn to deprioritize folks with substance use disorders. We learned as we round in the emergency room that let's let that person wait as we do this other person first, or let's round on him or her last with their substance use disorder. We're not going to do anything for them anyways. And we have all these attitudes that you learn as you go through curriculum. You also likely don't have a lot of mentors that specialize in addiction, right? And partly because you can't choose addiction out of medical school. So you are choosing psychiatry or you're choosing medicine. And so you're not choosing addiction right away. And so, you tend to not seek that right support, and it's not often not an integral part of the curriculum. And so you learn that perhaps it's not something you should pay attention to as you go through your training. All right, so why might our attitudes be negative? Again, we're not different than everyone else in society. We may have these personal experiences, attitudes related to the brain disease model. I'll add the attitudes towards race that exists in society and medicine, lack of knowledge and skills, these repeat negative experiences, and then this hidden curriculum that exists in medicine. There are a couple other reasons, I think. I'm curious your guys' thoughts at the end, and we should have plenty of time for you to think about those with me. All right, so attitudes are worse in society. They're worse in the medical profession. The odds are that each year you guys go out from this talk, your attitudes will decline. So is there anything we can do about it? I think so. One is we have to address our own substance use. If you guys are struggling, med students are struggling, you've got to address it, because the problem is we never do as doctors. We're the worst patients, and that includes for addiction. And so the window between illness onset and impairment may be over 6 years in the physician population. We present later because of the stigma, right? And there are these systems in place, like the physician health programs, the PHPs, which are mechanisms to evaluate, refer to treatment. They're not the licensing board, but sort of someone that can work with you in a way to help you have a good outcome and not lose your license. And for doctors that do get into treatment, once we get into treatment, we present late, but once we get into any sort of treatment, we do great. I mean, we're good students, right? We know how to follow along mostly. And so, it's just about identifying it in ourselves and seeking help. And so that's something I try to tell the students at Cornell whenever I see them and my residents that, don't wait to address this in you or your peers, because you're going to end up losing your license. You want to be captain of your ship, especially as us in medicine. We don't want to be derailed. And so if you're going to be captain of your ship, you got to modify these things early. And I'll say, as a psychiatrist, and it's something you all should think about in the future, some of my most rewarding work is working with doctors and other people in the healthcare field. People really get better. They're motivated. You know, at times they've had bad outcomes like temporary suspensions of licenses or bad things happen, and they're still motivated to get back on because they're often very passionate about medicine and helping others, and they don't want this disease to get in their way. This has been better over the last year, and I'm sure you've noticed this in your home institutions, but you know, we need to create interventions that reduce racial bias. I think how to do it well is still an outstanding question in a lot of medical environments. And, you know, there's a lot of, I would say to the stigma of addiction as well as to racial bias, people always sort of acknowledge it, and then they sort of make you do a rote exercise to acknowledge it. And then we don't look at behavioral change or other, or look at other ways that it's being modified. But hopefully we'll get better with creating interventions that reduce racial bias, because I think that'll help us as clinicians, it'll help our patients and everyone else. And part of this is reducing disparities in the healthcare force, in the workforce. And, you know, we want people from diverse backgrounds, including, I think, people with substance use disorders. I wish you guys as medical students could disclose on ERAS that you're struggling with substance use if you are, and that we would still accept you and want that, because it prevents it, as we would champion the person who's in recovery from a medical illness. Like everyone always, if there's a medical student that's in recovery from cancer, it's always the first line of their sentence, right? But I've never seen someone put it in the first line that they're in recovery from addiction, even though I know there's more in recovery than come forward. My thought. But there's still a lot of stigma that prevents it. And so I think, you know, how to encourage that and how to sort of get people open and honest about it. I did this huge event at York-Presbyterian where I work that was broadcast to all 10 NYP hospitals on dialogues and diversity. And I wanted to recruit a doctor in recovery at NYP, because I know one thing that's nice about going into addiction is that and I'm on the consult service, so I'm always around the hospital, is that everyone comes up who's in recovery and tells you. They're like, hey, Avery, thanks for doing addiction work. I'm actually in recovery myself. And so tons of people in the healthcare, in NYP, doctors, clinicians are in recovery. I asked, no one wanted to do this event at NYP. No one wanted to talk about it. They'll whisper it to me as I walk the halls, because I'm a friendly face, even, you know, despite the baldness. But they won't talk about it. So we got someone to talk at this event who was sort of an executive at York-Presbyterian who was in recovery and talked about coming forward with it. But I still remember I couldn't get a single clinician to come forward for that event. And I think that's a real problem. And there are different initiatives through the American Academy of Addiction Psychiatry and national organizations like REACH. I think REACH is through SAMHSA. I'm actually forgetting now. It's basically encouraging, with funding and other educational opportunities, psychiatry residents to go into addiction fellowships down the line. I think we need more addiction clinical programs. You know, Cornell's starting a new addiction psychiatry fellowship this summer that I'll be leading, but not just for psychiatry, but also you know, addiction medicine is increasingly a big field. So people can go into addiction through psychiatry. But these days, you can actually take a fellowship in addiction, even through other primary care specialties like internal medicine, ER, et cetera. And so I think we need just an expansion overall to address this inadequate addiction workforce that I mentioned earlier, so we can have a positive hidden curriculum and we can see people that are going into it and want to be like them. Because I'm all about the positive hidden curriculum. I mean, I think it's so key, and you know, I think I use Narcan a lot to sort of highlight my different initiatives. But you know, we should all be out there celebrating, helping people into recovery and be enthused by it. All right, we certainly need more education. I wonder how much education you guys have had in this in the Zoom call. I'd be curious to hear later. But we should be learning about stigma and language and the different therapeutic and medication strategies. We should know all about the neurobiology of addiction, where we can sort of help teams be aware of it in the hospital. Luckily, there's a lot of great resources these days. I mean, we're not short on resources. And one of my favorites is the pcssnow.org, which is a website, a nationally sponsored website that has webinars and modules on everything addiction. You can get free addiction mentors. And so if you're looking to pursue your own information or training on it, I would definitely look at that website. I'd look at the American Academy of Addiction Psychiatry website, or the American Society of Addiction Medicine. There's wonderful national organizations that provide training, that provide mentors, that I remember my first time as a psychiatry resident at the American Academy of Addiction Psychiatry meeting. I was like, oh my God, there's so many addiction psychiatrists. It's amazing. And they're sort of a great relaxed group. So yeah, we should be learning about the biological model of addiction. We should be learning how to do the substance use history. No one knows how to take a substance use history. It's the worst. Everyone gets so squirrely around substance use. If I hear one more person say, this is a question I ask everyone, I'm just going to explode. Like you just have to relax into that space and say, how much alcohol are you drinking? How much weed are you smoking? I mean, people know I'm cool with it. So they literally shout at me what they use as I walk down the street, just because they know I'm so relaxed into that space. And so you just got to relax. Otherwise, anytime I've seen someone take a substance use history, they're like backing out the room when they say it. So, this is our purview, and we have to feel comfortable assessing it and offering the treatment for it. And there are great treatments. I recommend you guys as students, if you haven't, sample an AA meeting. It's easier than ever these days because you can do it on Zoom during COVID-19, get a feel for it, go to an open meeting. You can put yourself on mute and the screen off and just hear some of the stories, or go to a smart recovery meeting. That's sort of an AA alternative. That's sort of like CBT light for substance use. Again, this is a great time to sample these things as a student, because they're all been transitioned, or some are transitioning back to in-person, but they're all virtual right now. You can just click on a Zoom link and participate or hide or whatever, just to see some of these stories. And then the big psychosocial treatment I'm encouraging all of you to learn is motivational interviewing. Motivational interviewing, I think, is why I never get burned out with working with folks with substance use disorders, because the spirit of it is you're just meeting people where they're at. Because what we do in medicine is a lot of finger wagging and information dumping. What are you doing using in that way? You're ruining your liver, your kidney. It's impacting your significant other, your family. Why are you using substances in that way? You're going to die. What's the problem with that approach, that finger wagging, information dumping approach that we love, white coats on rounds approach?
They're just gonna want to do it more.
Yeah. And who wants to talk to someone that's going to do that anyways? Plus, what's everyone in the life of someone with a substance use disorder telling them? Why are you using in this way? You're ruining your liver, your kidney, your life, our family. What's everyone with a substance use disorder telling themselves? What is wrong with me? Why am I doing this? I'm ruining my life, my family, my kidney, my liver. So if we as a medical profession just dump the same info that they already know, then they'll just, it's not going to help them. And we love, I think in psychiatry, when you go into it, you sometimes think this world is full of like aha moments, like you're going to tell them about their mother and then they're going to skip off into the sunset or something. The reality is that we're just meeting people where they're at, and that's the MI spirit. I'm just meeting with them where they're at. I'm rolling with resistance. I'm making sure they know their options and that they're heard. And then I'm not expecting cathartic moments. Those are rare. You're just in it with people. That's the spirit of psychiatry. You're just in it with people in non-judgmental ways. And I think MI can really emphasize that for you, because it really helps you step back and to do that. And so, I mean, people sometimes get discouraged with me. I'm on the consult service at the hospital. They expect me to come in and then we're like, they're never going to use again. But that's not life. We're meeting people where they're at, seeing where they are in their health timeline, and helping to nudge or provide options in any way we can. And so motivation interviewing will teach you that. So there's a great website, I think it's mint.org or com. It's the Motivational Interviewing Network of Trainers. And the beauty of COVID-19, I mean, it's brought a lot of grief, obviously, but so much of the content of these things is online now. So like you can sample an AA meeting online. Motivational Interviewing Network of Trainers has great online modules on motivational interviewing and seminars and mix of live and recorded stuff. So I think it's worth checking out. I'll skip this for now. I think the other thing that's helpful for Stigma is that we're bringing people out of the meetings, out of the AA meetings and 12 steps, and we're incorporating peers into medicine proper. So I think, as I mentioned at the beginning, people in recovery have been a big part of my anti-stigma work. And so, for example, at the hospital, I try to get peers in recovery to come talk to medical professionals, to come talk to my patients that are in the hospital or struggling with substance use. And so, I think that emphasis that there is a community out there is so important. And then there are great meds for substance use disorder. They should be teaching this all the time in medicine. Great meds for alcohol use disorder that no one offers. You need to offer meds for opiate use disorder, otherwise people are going to die. But tobacco use, a range of other substances, there's a lot of cool novel interventions from TMS to, ketamine, psychedelic treatments. I mean, there's just a lot of good stuff that's being developed. And so if you want to learn more about all that, it's not the purview of the Stigma talk, but just to know that there is good treatments out there. Again, the American Academy of Addiction Psychiatry, American Society of Addiction Medicine, SAMHSA, that pcssmath.org website. I mean, there's a lot of great ways to learn about all of this. All right, I think we also need new ways of teaching. I don't think we do a good enough job with not just substance use disorders, but co-occurring disorders. Like my wish for psychiatry residencies is that they didn't go disorder by disorder, but they more sort of appreciated that, let's think about schizophrenia and nicotine together because it's so co-occurring. Bipolar disorder and substance use disorders almost got teased out into a separate diagnosis because it looks like it responds to Depakote more than lithium. And we should be thinking more about how to address co-occurring disorders and thinking in that sort of case conference approach and not just one diagnosis at a time. And so that's one of the things I'm arguing. And then I hope this isn't the only time and space you guys think about stigma throughout the rest of your lives. I mean, I think we need time and space throughout our curriculum to pause for a minute. We did this exercise with the emergency medicine department actually at Cornell recently, is that we had a space where they could just tell me and some of my resident that was working on it, that, how you feel about these folks that you're seeing all the time with substance use, and we incorporated some attitudes to borderline personality disorder. Let us know and get the space to process it, give some information on the disease model, reflect. And I think that went a long way for that group. And so we do need, from psychiatrists to other specialties, permission to get these feelings out there in a way that we can understand. And because you can't exactly stop feelings if you haven't learned that yet. And so part of our job is to just acknowledge them so we don't do crazy things because of them, right? And so you may feel a certain way because you've had X, Y, Z experience, but let's not bring that into this clinical encounter. And so if we can create the time and space to do that, I think it could go a long way. And just as we should incorporate people in recovery, I think we should incorporate all these families who have lost loved ones, and Robin and a number of these groups. You can go to our website, substanceuseStigma.com. Well, it doesn't have all the recent modules, but I think families hearing from those who have lost loved ones is so important, and to helping us understand what everyone's going through. So from recovery and from people, I do have this website, substanceuseStigma.com. There's actually a newer website that's not here. That's it's the Cornell Psychiatry. I wonder what the link is. It's a substance use stigma institute. It's a new website. It's got a bunch of other modules and content, not just this one. We did study that module though on substanceuseStigma.com. It's basically a 7-minute module that has people in recovery talking, the family member who lost a loved one to the opioid epidemic talking, that describes stigma, describes the disease model of addiction. And we studied the impact of that on internal medicine and psychiatry interns, this sort of brief online intervention. And we showed that improved attitudes towards those with alcohol use disorder and towards opioid use disorder. Basically, if you just make people aware of it, I don't think people are talking enough about it. Just very brief awareness exercises and permission to feel a certain way and to acknowledge it, I think can go a long way, although certainly all those other things that I mentioned prior. This is a new video we created at the beginning of 2020, Taylor's story, with a family who lost, Taylor's family, Taylor passed away from an overdose, describing their experiences, that I think is powerful. And other, not just Cornell and NYP, but number of other places around the country have incorporated this module and others into learning about substance use disorders. And then I think we need a lot of policy changes in medicine. I mean, I think policy governs a lot of why we do what we do in the hospital setting, if you haven't learned that yet. And so I would love for all hospitals to make it very hard to not give out Narcan kits and buprenorphine for those with opioid use disorder, meds for alcohol use disorder, to pay attention to how long these folks are waiting in the emergency room compared to other folks. I mean, there should be policies in place that make, I mean, as I was mentioning with the change that relates to racial bias or the stigma of addiction, you need behavioral change to enforce behavioral change, I think, in a, not in a finger wagging way, but in an evidence-based, health promoting way, if you're really gonna make a difference. And so, for example, we put this policy in place in the emergency room at Cornell, where we made it easy for them to give out naloxone rescue kits. I normally give this talk in my office, and I have Narcan kits to show, but I'm at home, as I mentioned, so I do have a Narcan kit downstairs, but by the time I get there, I'm kids. But basically, it's a nasal spray that's very easy to give out, and you can squirt in someone's nose and rescue them if they've overdosed. And when we introduced this in the emergency room, I mentioned earlier is that ER doctors have the worst attitudes towards those with substance use disorders. This little bag improved their attitudes towards those with opioid use disorder. And you can just imagine why, right? You feel like you have nothing to offer at times if you're an ER doctor, someone with opioid use disorder, you're just going to stabilize them and discharge. And now you have a Narcan bag to give them. You have an intervention to do. And ER doctors love that. And so, and it's a life-saving thing. It's a way to rescue someone's life. And ER doctors are all about saving lives. And so I think Narcan kits were a good policy change in our emergency room. You know, and then there's a lot of ways for students to get involved. We have a clinic here, and Columbia has a similar one that I help with from time to time, and you know, helping with harm reduction and Narcan kits, and I think all of us, not just me, should be spreading the word that we should all be very active in this space. And I never thought I would be on Twitter and Instagram, and I do neither well, but my spirit is that we've all got to get out there and get into schools and interact with our legislators and make sure that we're advocating for our folks with substance use disorder, even in small ways. When you guys are rounding in your clerkship rotations, if you can be the advocate, the one person who stays and helps someone with substance use disorder, you'll really enact change more than anything. I mean, the thing is that change, this is what people forget as they disavow the disease model of addiction. It's both the disease and the change. The ability to change is so great with this disease, right? Every other medical condition, I think, is just holding on for dear life until death, isn't it? This is one where you can really make a big change and get people to a better state. And as much as we can champion that, the better. All right, to summarize some of what I've said there, though. So what can we do? We can address physician substance use, racial bias, expand the training programs, get this positive hitting curriculum, increase knowledge and skills, increase awareness of and interventions for stigma, policy changes, and then certainly, hopefully, all on our soapbox spreading the word. All right, so further things we're doing. I certainly am interested in further characterizing stigma and clinicians' attitudes. I actually have another number of recent studies that I don't have in this talk, including sort of examining pediatricians' attitudes towards those with substance use disorder. I've done a lot of recent work on that. You know, since a lot of addiction emerges in the adolescent population, and it's a group of clinicians, including child psychiatrists, that don't feel too equipped to address substance use. And so I studied their attitudes towards vaping, nicotine, and towards opioid use disorder, and they're negative, and have done a number other of studies, not just in the healthcare profession, but in lawyers and family members and general public, sort of sussing out, you know, where these different attitudes sit to sort of better understand them. We're working on, I mentioned a couple of interventions that are particularly targeted towards stigma. So like our substance use online modules. We actually have a number of in-person interventions that I do around the hospital that have been studied and have been shown to be pretty effective. But especially in the setting of COVID-19, we're trying to use new technology, different sort of interactive gaming, or I have a partnership with MIT and some other places to sort of make some funner interactive online modules that allow people to play with stigma and substance use, and so that they can both awareness, but hopefully as some ways to also measure behavioral change as we go through it. And then we certainly are hoping to expand resources for the development and education of addiction-focused clinicians. And so my hope for all of you in this room is that you guys are the next generation of folks that take care of folks with substance use disorders, that, you know, no matter what you go into, you view yourself as an addiction provider, no matter what your specialty or fellowship, to recognize that there's often nowhere to refer these folks, and they don't want to go somewhere else. They want it from you. And so wherever you encounter someone, if you can be the clinician that they need, the clinician that seeks to understand them and offer treatments for their substance use disorders, you know, I think that can go a long way. All All right. So it leaves us a good 10-15 minutes for questions, I think. And so happy to, so I'll stop my share and see if any of you guys have any thoughts or questions about any of that.
Thank you so much, Dr. Avery. So definitely, please jump in, everyone, with any questions you may have. I think we can all agree that was an extremely eye-opening lecture, and I think we all definitely need it, especially during this time with the pandemic, and we're seeing addictions on the rise. So definitely jump in, folks.
Hi, so my name is Ryan. Very good presentation. I appreciate it. My question has to do with the legalization of drugs and the impact, either positive or negatively, on addiction in this country. New York City is getting ready to legalize marijuana recreationally. You have other states like Oregon that are on the path towards legalizing everything under the sun. So I just wonder how those policies will impact addiction, and if education can on appropriate drug use in those situations can impact that in any way.
Right. That's the $1 million. That's a great question. If you ever go to an addiction meeting where that question's asked, people are like throwing chairs like 10 minutes later because it's it's such a complicated space. And so, I mean, as I mentioned with some of the talk on the legal stuff, the problem with current policies or the way they're enacted is that we end up imprisoning and jailing all these folks with substance use disorders instead of offering them care. And there might be a range of racial and other biases that go into it. And so that doesn't seem good to me. And, you know, other states, you know, other countries, Portugal, and, you know, worked on decriminalization. And I certainly hear all the objections to legalization, including sort of the idea that it'll get it into more hands of adolescents or sort of make people think that substances are more safe than they are. And so my hope is that, and where I'd like to think things go sort of irrespective of the legal system, I think the things that need the most change are just easier to access treatments, non-stigmatized, low threshold treatments for those with substance use disorder. So if I had to put my money anywhere, I would put it not into legalizing or enforcing laws. I would put it into more treatment and better evidence-based care, which is sort of a non-answer. And I can hear the arguments both for the legalization and not of marijuana, and be swayed at different points for either of them. Although I can't stand people being imprisoned for substance use disorders and their lives ruined. So, and I try to be diplomatic and as friendly a face as possible.
Yeah, there's a lot of criminal recidivism that goes on with criminal records associated with drug use. People can't get jobs and they go back into those situations. Absolutely.
We just put people in a position where change is impossible the way things currently are. And so, you know, that's not sustainable. And, you know, and, you know, alcohol is legal. I mean, there are a whole bunch of ways to address why and how people use that. And you know, the treatment landscape of addiction is awful. Rehabs are terrible. So many of them are not evidence-based, and they take your $80,000 and you're no better off a month later. And so, you know, we just need so much more energy into addiction clinicians, better evidence-based care, people making care accessible to everyone across the socioeconomic spectrum. If you're a 16-year-old struggling with addiction, what are you gonna do as a parent and family? There's like no good options. Very few insurance based around the country. You're going to goon them and take them to a wilderness camp for 3 months that provides no mental health care. I mean, it's just so unclear what to do. And so much more resources need to be dedicated toward those with substance use, I would say. So I'm more interested in the treatment end, but I hear all the complications. So I'm not sure how it's all going to shake out legally or what it'll mean, but we're here to treat and hopefully get more treaters along the way.
Thank you.
Sure.
Kind of continuing that, I've spoken to a lot of psychiatrists who, you know, will say they're like, a lot of them are proponents that, you know, things like marijuana actually like precipitate other mental illnesses such as like schizophrenia. So I'm kind of curious if you think that maybe perhaps psychiatrists should be a little more outspoken in kind of combating perhaps legislation that might make it easier to acquire marijuana. Just wondering where your thoughts are on that.
we don't want, it's complicated, I think. I mean, we don't want our adolescents using marijuana with their vulnerable brains. We know if you started using weed before 18, it doubles your odds of developing a marijuana use disorder. But we know about, 9% of adults who end up using marijuana are going to get a marijuana use disorder. Much more people get into trouble with alcohol. I mean, at York-Presbyterian, for example, we have like 9,000 presentations a year for alcohol use disorder, like 1,000 for opioid use disorder, and very few presentations for marijuana use disorder in terms of the medical complications. So some of these legal substances and some of our prescribed substances are causing much more morbidity and mortality than marijuana. At the same time, if you start using, especially when you slip into self-medicating with marijuana, you start using it daily, it's very clear it doubles and triples your odds of anxiety, depressive disorders. Everyone likes to talk about it being one of the biggest modifiable risk factors for chronic psychotic illness and its role with psychosis, especially with these high potency. Like when your mom was smoking weed in the 70s, it was like 3% THC, and now it's like 25%, and you get these incredibly more potent preparations that can lead to sort of acute and chronic psychotic states. And so even the youth vapors that get into trouble with weed they're doing the bootleg devices and ending up with those EVALI and those lung injuries. So it's dicey. I mean, we definitely we want to treat it like we treat alcohol. I think we want to understand why people are using it, see if we can get to help providing them with healthier alternatives to it, and certainly be there to offer treatment if it's necessary for the mental health or substance use. We shouldn't all be like smoking at the annual meeting, but it's hard to figure out how to have nuanced attitudes overall, I think.
Definitely hear you there, Dr. Avery. It's complicated.
I wanted to do a study the study I wanted to do was how much weed are med students using and what do they tell their patients about it? And just as it was a thought leaving my brain, like everyone shut that down. Like no one wanted like the New York Times headlines, like, New York hospital medical students using records amount of weed, don't know what to tell their patients about it. But I was interested in that study because a lot of med students and faculty and residents all the time are coming up to me and saying, how long is weed going to be in my urine screen? Because they're going to urine screen me for the first time in residency interview. Or I'm doing an away rotation and I heard they're going to urine screen me. Help. So, I mean, it's among us, and there's a range of attitudes. There's a range of studies going on looking at the role of the cannabinoid system, and CBD and other preparations can help with mental health conditions. And so I'm the king of non-answers today. I can't even remember the question at this point. What else you guys got?
I have a question about stigma specifically. You mentioned how one of the best things that we can do as future physicians is to check our own stigma and be more aware of our maybe unconscious or subconscious beliefs and attitudes towards those who struggle with addiction. Do you have any recommendations or resources, best way to go about just checking yourself when working with someone who struggles with addiction?
Yeah, that's a great question. I think anytime you notice you're not doing something that you would normally do for other patients, whether it's too much in one direction or the other, positive or negative, I think that's always an opportunity to step back and wonder what's going on. And so, it's sometimes easier to sort of say, oh, why am I being trying to save this guy, as opposed to saying, why am I avoiding this patient, or why do I not like him or her so much? And so I think one thing is just to pay attention when it looks like behaviorally we're doing something different, and give ourselves permission to breathe and to sit with some of those uncomfortable feelings that it may involve. I wish there were more spaces where we could do this with others, though. I think it's so hard because at times the whole system is doing the same thing. We're not just doing it as the med student, we're our residents doing the same, our attendings doing the same. And so I think while individual, it's great that each of us is paying attention to our stigma. I do think it would help if all of us had the space and time to sort of sit and reflect on it. And the good thing about psychiatry residencies, and I think all you are going in there, right, is that you guys will have process groups that you address sort of the group dynamic that goes on in psychiatry, but it's also a place to think about attitudes towards patients and all this stuff. And so certainly in psychiatry, we encourage you to reflect on any countertransferences or attitudes that develop along the way. The other thing that I think can be very helpful in being aware of our stigma or being aware of these folks in general is to get exposure to people in recovery, and to sort of hear these narratives that are more broad, because I think it'll help us have a little more hope that people can get to a space that is positive, and we have to often carry that hope for folks that are struggling. And so I think that can help as well. That's a great question, though. Thanks.
Thank you.
I had a quick question about AA and NA. I know you mentioned both of them, but I've working in the community with a primary care doctor. I've heard that they frequently don't allow their members to use things like Suboxone and methadone. And I know NA and AA are usually, they don't have a kind of a national policy it's per group. But how do you think about sending people to AA and NA in the context of some of them having kind of stricter interpretations of what sobriety is?
Right. And the background to that question is that in the world of addiction, there's all substance use disorders on one hand, and then there's opioid use disorder on the other hand. And the reason we tease them out is because of one, how opioid use disorder presents, which is overdose and death. As I mentioned, the overdose statistics at the beginning. So doctors overprescribed opiates, and then it comes at the real risk of death. And so opioid use disorder is different in that people are at risk of dying. And then it's different because we feel like people with opioid use disorder 100% have to be on medications: buprenorphine, methadone, or Vivitrol. And the reason we think you need to be on these three medications is that if you're not, you'll relapse, and relapse rates at 1 year approximate 100%. And again, what happens when you relapse? You die. And so it's very clear, especially for opioid use disorder, that AA, NA, 12-step, really any psychosocial treatment is not sufficient care. And so if you're just going to a 30-day rehab and not on buprenorphine and then being discharged to the community, that's where you're going to overdose and die. If you're just trying to do AA or NA for opioid use disorder without those meds, the relapse rates are so high. And again, they come with the risk of death. And so in the setting of the opiate epidemic, AA has been careful. And they even came up with some national announcement, or it was in a brochure or something, and trying to encourage their members to not tell people to discontinue their meds for opioid use disorder or their meds for psychiatric treatment. And so I think while historically there has been this view, and there still is, I mean, the meetings aren't regulated and every meeting's different. And some do have this view that real recovery involves complete abstinence, but I think that's changed a lot. And I think buprenorphine and meds for psychiatric conditions are more accepted in the 12-step spaces than ever before. But it's something to be mindful of. And I am mindful of folks, and I often check in with them if they found these meetings helpful, what they've heard about the attitudes towards their psychiatric or medications for substance use disorder care. People often need it, though, because they need a sober community, or they need some sort of community that's different from their current one in order to change. And so AA is definitely not for everyone. And so that's why I like Smart Recovery. There's a lot of AA alternatives. There's moderation management. There's a lot of great alternatives that exist. And so, but I often have them try one to see, or try a couple to see if they're good fits, just because it's hard to change in isolation. Everyone needs some community. And I'll say that I've heard less people telling them to discontinue. The real problem for New Yorkers is that they don't like some of the steps that say they're powerless to a substance, or they don't like the sort of intensity of the community or the religious aspect or things like that, just because we don't even talk to our neighbors in New York. And so we don't want to do 90 meetings in 90 days and people texting us. And we also don't like to admit that we're powerless to substances in New York. We like to think we're so powerful that we can change. And so often I hear people in New York balking at 12 steps just because they don't want people in their business and the time commitment, or they just don't want to be powerless. And so I see often those complaints even more than sort of asking to discontinue their psych care of late. But it's something to be mindful of, because there are groups, and I have heard it even still, that people tell them they should stop their Suboxone or whatever.
Good, thank you.
All right, I think we have time for one last question, folks.
I have one real quick. Dr. Avery, thank you so much for your talk. This was so interesting to listen to and just think about different avenues. Just in kind of reflecting on stigma and breaking stigma and kind of the unique opportunity we have as physicians to interface with these issues at a more personal level. I was just wondering what you thought or what role you think that physicians should play in advocacy, just kind of thinking about how all these policies, whether it's incarceration or drug laws, just from, what everyone has brought up, how we should participate, and whether so far in your career you've found that there are adequate opportunities to either participate in a way that doesn't take away from practice, but also allows your experience kind of on a firsthand basis to be represented on some of these larger decisions that kind of affect the whole culture.
Yeah, that's a great question, and we definitely need more advocates. And I found a lot of ways, from small ways to big ways, from the letter writing to actually joining in on a lot of initiatives to have been very rewarding during my career, because you feel it as you take care of individual patients. The way that society's treating it is really impacting their health and the health of frankly you as a provider and them as a patient. And so there's a lot of advocacy that goes into our profession, because we're stigmatized as a profession, and we're often not treated the same as other clinicians, and our patients aren't treated the same as other patients. And so I think there's a whole bunch of ways to get involved, and we need more people doing that good work. It's hard because there's a lot of things doctors turn out to be. They train us to study and to take care of patients, and so we don't really learn how to advocate in that way and to be involved in policy. We don't learn how to manage finances. We don't learn. All we learn how to study until we're dead, I think. And so I think it's worthwhile seeking out these other avenues, because they're rewarding and they benefit us and our patients. And so I'm hoping all of you can do that as well. I think that's great.
Thank you.
All right, thank you so much for your time, Dr. Avery. I think that was so enriching, so informative, and so helpful, as well as entertaining. I think everyone was really engaged, and we learned so much today. I think we'll all take this in our books as we forge forth as future psychiatrists, and hopefully we've all learned a lot about advocacy today.
Thanks so much for having me. It's a great conference. I wish I could say and see Dr. Pender. I see her, she's joined. She's amazing for your next speaker, but I've got gymnastics practice. So, but I really appreciate you guys inviting me and thinking about this. And always feel free to reach out, no matter where you are, for any of these things. Consider. I don't know if you guys have my email or not. I can put it in the chat real quick. But always feel free to email or call. I'm happy to help as we go through it.
Absolutely. Oh, there's Dr. Pender. Hi, Dr.
Thanks,
Pender.
Jonathan. Good talk.
Good to see you. Thank you.
All right. Thank you so much, Dr. Avery. We'll all be in touch with any questions that couldn't be addressed in the time we have.
All right. Thank you.
All right. Thank you. Take care. All right. Good morning, Dr. Pender.
Good morning.
So happy to have you join us.
Thank you.
So
happy to be here.
Yes, absolutely. Most of our students are tuning in from New York, I believe, but we have a couple of international students. We also have, it's pretty much all over from the US. I've opened this conference up to everyone. So I think there'll be people kind of tuning in when they can. So there may be people in the waiting room at one point or another. So you may see the numbers changing below for the participants. I just want to give everybody a chance to take a bathroom break or do anything they need to do before we start our next session. So the time is now 11:58 a.m. EST. We will resume for Dr. Pender's session at 12:05 p.m. EST. Okay. All right. Thank you, everyone.
See you soon.
See you soon.